I'd like to now invite Dr. BIDISHA Mahapatra. She will present two talks. Again, a posterior capsular rupture, along with during nucleus management, and a second talk would be whether or not premium IOLs can be placed in a patient who has had a PC rent. Thank you. Bye-bye. Thank you.
Good evening, one and all. I shall be presenting on behalf of Dr. Sudeep Das sir, who could not be present due to some issues. So, management of PCR. These will be basically surgical videos. So, in this first case, what
Talk
we
a little
see.
louder. Come closer to them.
In the first case, what we see. Phacoemulsification is completed. Epinucleus removal. At the end of that stage, the surgeon notices a PCR and it is converted into a posterior capsular rhexis. There is no VL and IOL is injected into the bag. So the important thing was the PCR was converted into posterior capsular rhexis, and then after that we can place the lens in the bag. And then the remaining part of epinucleus is aspirated. In the second case, it is a posterior polar cataract, bit on the harder side, maybe stage 3. So surgery otherwise goes well. The nucleus is emulsified well. So the nucleus is completely emulsified, and after that what is noticed is there is a PC dehiscence there.
Come closer to the mic.
Yes, so there is a PC dehiscence now. So the thing is, inject visco and then come out. We should not come out, bring out the probe without injecting visco. So again, till now there is no vitreous loss. The epinucleus is brought out and it is emulsified. So from the other hand, again visco goes in. Cortex is aspirated. And again viscoelastics injected. And the lens is dialed into the bag. This is the next case. It is again a posterior polar cataract, but it is a softer one. So the endonucleus is emulsified. While removing the epinucleus sheet, there again we notice there is a PC dehiscence behind. Viscoelastics are injected. Remaining epinuclear sheet is aspirated. The aspiration is being done within the left hand. There is viscoelastics injected continuously, and then the PC rent is converted into a posterior capsular rhexis. So there is vitreous now. Antravitrectomy is done after completing the posterior capsular rhexis, and then goes the IOL into the bag. This was a hard cataract. During the last piece emulsification, the surgeon notices a PCR behind. So under continuous irrigation of viscoat, the emulsification is being carried out. And then IOL is injected into the bag. This is a case of a black cataract where at this stage a PCR is noted, and then the surgeon uses a scaffold technique of completing the rest of the phacoemulsification. It's a bit risky thing, which I think maybe very experienced surgeons can only take the risk of this. So a 3-piece foldable lens is injected, is kept above the iris. Now in this step, the main thing will be protecting the endothelium. Of course, we have to use profuse viscoelastics and then complete the emulsifying rest of the pieces. And after completion of emulsification, the IOL will be dialed into the sulcus. It's a 3-piece foldable IOL going into the sulcus. So the points to be noted are: watch out for early signs of PCR. That can be the difference between an excellence and a disaster. So the signs of seeing folds in the PC, any unusual movement of any nuclear bit, sudden failure of holdability or followability, any slight change in antechamber depth, and one can always train oneself to feel the pop of the posterior capsule giving away. Always keep good dispersive visco OVDs ready at all the times. Master antravitrectomy and posterior capsular rhexis, and then choose the appropriate IOL for implantation after PCR. Thank you.
Dr. Bidisha will now. I think, Minu, are you good to go straight away?
Yes, ma'am.
Okay, then I'll let her finish. Dr. Bidisha, on behalf of Dr. Sudeep, will now present her second paper. Can premium IOLs be implanted in patients with a PCR? Just stand a little closer to the mic, dear.
Okay. Yes, ma'am. Can premium IOL implantation be done following a PC rent? Any intraocular lens of choice can be implanted in the bag if the posterior capsular rent is converted into a posterior capsular rhexis and antravitrectomy, if necessary, has been done. If the PCR is large with insufficient PC support, implant a 3-piece foldable intraocular lens in the sulcus with optic capture whenever possible. Reverse optic capture of a single piece foldable IOLs need exceptional skills, and there is high possibility of the IOL dropping while doing this. Reverse optic capture of 3-piece IOL is easier and safer. So choose an appropriate monofocal IOL over the promised premium IOL if necessary. So this is a video of a hard cataract being emulsified. The surgeon is polishing the PC, and it was actually a hard cataract with a posterior polar component. And the last stage, what he sees is a peripheral PCR there. So there is no VL, and the PCR is converted into a posterior capsular rhexis. And it's a multifocal IOL going into the bag. So the point was, in a posterior polar cataract, either we should not do a PC polishing or should be very cautious while doing it. Next is a brown cataract in which PCR happens during irrigation aspiration. It was a case of toric intraocular lens implantation. So it's a brown cataract, you can see it. Emulsification goes well, but during irrigation aspiration, there's a PCR. With vitreous loss. So no, there was no vitreous loss actually. So as soon as he notices a PCR, injects viscoelastics so that it doesn't extend, and then since there was no VL also, we can implant the IOL into the bag. This is a case of posterior polar cataract. So after the nucleus emulsification, PC dehiscence is noted, viscoelastics are injected, and the PC dent is large here. Antravitrectomy is being performed. After a thorough antravitrectomy, the remaining cortical matter is aspirated. And a 3-piece foldable multifocal IOL was placed into the sulcus. So the take home point is, Long-term outcome is more important than short-term economical goals. Choose the option that you would choose for your own eye. Thank you.